Assalamu alaikum, everyone. I am Farah Abul Rub. I am a third year medical student, and for today, we're going to be picking up where we left off yesterday with Brainstem Part 2. For this portion, we are going to mainly be covering the reflexes that are elicited by cranial nerves, the cross sections, where I want you guys to tell me a lot more than I'm telling you. And then we're going to be going over the lesions. For the lesions portion, I did not actually write much on the slides because I want us to figure it out together and write everything down together. And then after that, once I actually give you the slides, I will obviously provide everything, inshallah. Lastly, we will be going over a couple of questions after we take a short break. And we will be wrapping up with a final review of everything so that we can hopefully make sure that you guys understand all of Brainstem to the fullest possible extent. Okay, without further ado or delay, let us actually get started and try to figure out what is this issue with the brainstem, what are all those lesions that we keep on talking about consistently. And firstly, I would like to do that by reviewing the cranial nerves that we went over yesterday, specifically their nuclei. So we said that our cranial nerve nuclei are arranged based on function, right? We said that they are specific. Meanwhile, our cranial nerves themselves are not specific. So one cranial nerve might go to multiple different nuclei to actually relay there and get information from there. We generally classified our nuclei into general somatic efferents, special visceral efferents, general visceral efferents, and then we moved on to our afferent fibers, where we had our general visceral afferent, special visceral afferent, special somatic afferents, and finally our general somatic afferents. So, very briefly, we looked at the general somatic afferents, where we said that this is for our skeletal muscles, particularly in the eye and in the tongue. In the eye, we have cranial nerves 3, 4, and 6, which are responsible for the movement. And these nuclei would be both of those in the midbrain and then 6 in the pons. For the tongue, we said that the hypoglossal is the one that is responsible, and that is located within the medulla. Next up, we had our special visceral efferent. Whenever I'm talking about special, then I'm referring to the pharyngeal arches. We said that the first pharyngeal arch was for mastication, which was supplied by the V3 root of trigeminal, and this is located within the pons. It is one small motor nucleus. Then we had the second pharyngeal arch, which is responsible for facial expression, and this is supplied by the facial nerve. That is also located within the pons, but as you guys can see, it is closer to the medullary junction. Lastly, we had our third and fourth pharyngeal arches, which were responsible for the pharynx and larynx, which were supplied by our cranial nerves 9 and 10, which shared a nucleus called the nucleus ambiguus within our medulla. We had then our general visceral efferents, which is basically our parasympathetic fibers. Our parasympathetic fibers were responsible for four main features: our pupillary constriction, lacrimation, salivation, and finally the actual supply to the visceral organs. Pupillary constriction is carried out by cranial nerve number 3 through the Edinger-Westphal nucleus, which is located in the midbrain. What nucleus does this relate to, you guys, when it actually goes towards the target organ? Which ganglion? Inferior colliculus. Okay, so what is the inferior colliculus responsible for? The ciliary ganglion. Yes, there we go. The inferior colliculus is actually auditory, right? Remember I told you guys your eyes are above your ears? So the superior one is for vision, the inferior one is auditory. Okay? All right. So yes, you are correct. The Edinger-Westphal nucleus will give rise to the third cranial nerve, and then after the branch of the third cranial nerve, which will go to the parasympathetic ciliary ganglion, and that will lead to pupillary constriction. Next up, we had our lacrimation, which was through the facial nerve, and that was taken up by the superior salivatory, which is located within the pons. Do you guys remember what the ganglion was that was related to lacrimation? Pterygopalatine ganglion, absolutely. Now, for salivation, we have three different glands, two of which are once again supplied by the facial through the superior salivatory. But as you guys rightfully said, it goes instead to the submandibular ganglion, where it will supply the submandibular and the sublingual. Our parotid gland is the third of our salivatory glands, and it is supplied by the glossopharyngeal nerve, and this is through the inferior salivatory, which you can see here, and that goes to which ganglion? The otic ganglion, perfect. Lastly, we had our viscera, which were all supplied by our vagabond, our vagus nerve, and that vagus nerve takes up this portion in the medulla, so medial to lateral. Then we had our afferents, which were our basically sensory fibers. We started off with our general visceral afferents, which was once again parasympathetic supply to the viscera, and that is through our vagabond, our cranial nerve number 10. Our special visceral afferent is exemplified in taste, which is carried out by the trigeminal as well as, the facial as well as the glossopharyngeal. The facial is for the anterior 2/3, while the glossopharyngeal is for the posterior 1/3. Both of these together are going to share a nucleus called the nucleus tractus solitarius. Once again, guys, just for simplicity's sake, this is how I drew it, but remember that this would be more lateral than any of those motor structures, right? Those efferent structures. Next up, we had our special somatic afferent, right? This is what I told you guys was very unique because this is what gives us our hearing and our balance. And that is this small nucleus within the inferior colliculus, all right? Not to be confused with the actual vestibulocochlear nucleus, which would be here, all right? Just keep that in mind. Lastly, we have our general somatic afferents, which is the general sensations to the entire face and neck carried by our trigeminal. And this trigeminal has three separate nuclei that span the entire length of the brainstem. These nuclei are the mesencephalic within the mesencephalon, the principal sensory, so principal P for pons, and then finally the spinal because we're going closer to the spine. The mesencephalic was responsible for proprioception, the principal sensory was responsible for touch, and the spinal was responsible for pain and temperature. Is that clear before I move on to the next portion? Because it depends a lot on this, which is why I wanted to go over it. Is this clear for everyone? Crystal, perfect, okay. All right. So let us actually get started with the new portion of our session, which will be going over the reflexes as well as the sections. So first of all, I would like to once again reiterate the fact that although we have one cranial nerve, it can have multiple different nuclei, okay? So for example, our facial nerve, you can see that it has the nucleus tractus solitarius, but it also has its own facial nucleus. Is that clear? I don't want you guys to worry about any of the other details here because those you will cover in HNS, inshallah, once you get to that blog. Okay. Something else that I wanted to focus on is the fact that the trigeminal, although it in and of itself does not carry any parasympathetic fibers, all of the parasympathetic fibers for the remaining ones, which are our, what are they? We had three others that carried parasympathetic. Ignore the vagus. Vagus does its own thing because it's not going to the head and neck region, right? For parasympathetic. But we had three glossopharyngeal, perfect, it going to the parotid gland. Facial, perfect, going to the, for lacrimation and for salivation. It's too long saying everything. And then lastly, what was the third one? Guys, it's on the slides. It's on the slides. It's right there. Three, yes, okay. So the oculomotor, when it goes to the ciliary ganglion. So I want you guys to imagine that fibers from these three nerves are going to go and hitchhike along the trigeminal, but they will not actually mean that the trigeminal in and of itself is a parasympathetic. Is that clear? Perfect. Okay. Moving on to the actual brainstem reflexes, we have 5 main reflexes within the brainstem. Why are these important? Well, first and foremost, it is mainly the brainstem that is used to assess whether or not a patient is actually brain dead. And once that happens, we can realize that, okay, so this patient is basically like a do not resuscitate anymore. This patient is already, unfortunately, dead. So brainstem reflexes are very, very important, and they should not all, okay, be gone unless the patient is dead. Otherwise, some of them might be affected when their respective afferent or efferent nerve is actually also affected. So the 5 reflexes are the pupillary light reflex, also known as the accommodation reflex, the corneal reflex, the vestibulo-ocular reflex, the gag reflex, and the cough reflex. The cough reflex is not one we typically talk about very often, so I will just be discussing the first 4. The first one, which is the pupillary light reflex, I want you guys to imagine it yourself. Before I actually go through any of the pathways, before I go through anything, I want you to think of your pupil when you see something that's super, super, super bright. If your eye were to actually consistently be receiving this much amount of light, then this would be very, very damaging, right? Specifically to your retina, which is the back of your eye. On the retina, we have those pros and those pros, those rods and those cons, which are responsible for light detection. They're responsible for our vision. And if we were to constantly have this light that's aggravating them, they would get damaged. So what the pupillary light reflex does is that basically, once I shine a light into someone's eye, their pupil should be able to constrict. Okay? How does that happen? We need the second cranial nerve, so our optic nerve, in order for it to actually receive those messages from the rods and cones and tell the brain that, okay, there's too much light, and we need the efferent aspect, which is our oculomotor nerve, that comes back and actually does that pupillary constriction. Next up, we have our corneal reflex. The cornea is a part of the eye. I'm not going to go into the anatomy of it or the details because you'll be covering that in HNS, but the cornea is a part of the eye that is very, very sensitive. When the cornea gets even the slightest abrasion, it can be very painful for the eye. And I want you guys to imagine it as this outer protective layer. So when anything, including your own eyelash, touches your eye, your corneal reflex basically wants you to immediately blink, either to get rid of that aggressor or to close your eyes entirely so that it goes away. Okay? The vestibular ocular reflex is something that I want you guys to consider as basically, let's say I tell you to focus on a point, and then I move your head to the side, but I keep on telling you focus on that point. Or someone calls out your name from behind you, but you're looking at your screen to study, to play video games, for whatever reason. So you turn your head after you hear that person make that sound, but your eyes are still fixated at one point. This is the vestibular ocular reflex, or the vestibulo-ocular reflex, which is the correlation between the ear and your eyesight. And I will get to the details of that later on. Lastly, the gag reflex, which basically means that when the back of your throat, i.e., the soft palate, is stimulated, what happens is that your body is saying, something's wrong. Like, no, I don't feel like this should be happening right now. Okay. And this is very, very important. For example, when you swallow something that is too large and you're about to choke, this gag reflex stops and it spasms your pharynx such that you don't actually have to have that and you end up coughing, right? So those two are correlated. Let's take a look at each of these on a bit more intricate level. Oh no, where did the animations go? Did I not save? I think I didn't save the animations, but it's fine. Okay, let's pretend that none of this is here, and I'm gradually showing you guys all the animations, okay? All right, so let's orient ourselves a bit. Here we have our left eye, and here we have our right eye. Obviously, everything that is happening is bilateral. However, for simplicity's sake, I've only drawn it on one side. Here, right behind the eye, we have our ciliary ganglion, which is what we said is responsible for the parasympathetic to the ciliary muscle. Here, we have our Edinger-Westphal nucleus, which is where the oculomotor arises in order to actually go to this ciliary ganglion, okay? And then lastly, we have this pretectal nucleus. This pretectal nucleus is important as a relay center to basically work between the oculomotor and the optic nerve. So what happens is that when we shine a light into someone's eye directly, the retinal rods and cones here are going to sense this light. Through the optic nerve, they will send a message, which goes to the pretectal nucleus. Now, this pretectal nucleus is super smart. It does not only communicate with the affected side, it actually loops over to communicate with both. Okay, so as you see here, it supplies the Edinger-Westphal nucleus of the left as well as on the right. I do not think that you need to know all of these details, by the way, but it's just for the sake that you have a bigger picture, you have the entire picture, because I don't remember taking these in neuro. I remember taking them in HNS, but a lot of you did tell me that you did the reflexes, so just in case, I'm giving you this full picture. So if you don't want to remember all the names, that is okay, just know the pathway generally speaking. Okay, we got to the Edinger-Westphal nucleus. We get the signal that, okay, we have too much light going to the eye. This Edinger-Westphal nucleus is going to send the oculomotor nerve to reach the ciliary ganglion, okay? In the ciliary ganglion, we send out the short ciliary nerves, which reach the ciliary muscle to actually constrict the pupil. So although I'm only shining light, this is what you actually really need to focus on. Although I am only shining light on one eye, both of the pupils should constrict. Is this clear for everyone? It's like getting a behind the scenes of the workings of everything. Okay, perfect. Next, our corneal reflex. Once again, imagine that there are animations here. So I'll add them definitely again to the one that I sent you guys. The corneal reflex is what I told you guys that is the one that requires me to agitate this very sensitive cornea, and that leads to blinking of the eye. But once again, our brain is very smart. It does not only lead to blinking of one eye, it leads to the blinking of both eyes. I'm not sure if the animations would be there or not, but that's okay. I'll check after the session, inshallah. Either way, the one I send you guys should have them. Okay. As I was saying, we have our eye here. Okay, then we have looking at the side. So those are the actual eyelids. Okay, this would be our left eye, and this is the right eye. So what happens is that I come and I agitate or I touch the cornea. You can do this either with your actual finger, you could do it with a cotton swab, you could do it with basically anything that elicits this corneal reflex. Once I do that, I will have a branch from the trigeminal nerve. So this is a sensory, purely sensory, okay? The trigeminal nerve will go and synapse with the spinal nucleus of the trigeminal. Why? Because this was a touch, right? We said that the spinal nucleus of trigeminal is the one that is responsible for the sensation of touch. So as we irritate or agitate this cornea, it goes back to the spinal nucleus of trigeminal. The spinal nucleus of trigeminal will then communicate to the facial nerve on either side. So it will go to the left side, communicate with it there, and also go to the right side and communicate with it there. After that communication happens, the facial nerve will send out a branch to the orbicularis oculi muscle. This is the muscle that surrounds the eye. It is the circular muscle that's around the eye, and it is responsible for blinking. Okay, so it is responsible for closure of the eyelids. So once again, what is the corneal reflex? When I agitate the cornea, the trigeminal is going to go synapse with the spinal nucleus and give me two supplies, one to the left, one to the right, of the facial motor nucleus. This facial motor nucleus will then give me the facial branches to the orbicularis oculi muscle, leading to blinking of both eyes. So it's not just one eye either. Is that clear? Okay, perfect. The last one I will be discussing is the vestibulo-ocular reflex. And this is one that a lot of people really hate and it can be a bit confusing. So I wrote down this entire explanation myself. So tell me if it's a bit too hefty to read, but I will try my best to explain it on the diagram so that you can actually get a general idea of what's going on. Okay, so I want you to imagine this on yourself. Once again, I just told you, I want you to turn your head to the left. Okay? Turn your head to the left, but keep on looking at a specific point. What did I just do? By turning my head to the left, both of my eyes are still looking towards the right. Is that right? Because I want to fixate on a specific point. As I move to the left, as I turn my head to the left, what happens is that the fluid within the cochlea, which is that nail inside your ear, is also going to shift, specifically on the left side where I am turning. As it does that, the vestibulocochlear nerve, the eighth cranial nerve, is going to sense this shift in fluid. Okay? So the left side, since I'm turning towards the left, is going to sense this shift. As it senses this shift, it is going to communicate with the contralateral abducens nucleus. Okay? Why is it communicating with the contralateral abducens nucleus? Let's think about that. So the reason why I want the abducens nucleus to work is to pull on the lateral rectus muscle, right? What does the lateral rectus muscle do? It abducts my eye, abduction. So if I am shifting to the left and I want to continue looking to the right, then what do I need? I need this lateral rectus muscle to pull this way. And then here, this is the medial aspect. So this isn't the lateral rectus, right? This is the medial rectus muscle instead, and this is by the third cranial nerve. So everything that is happening is basically for me, as someone that has just turned to the left, that wants to move the eye to the right, to pull at the left lateral rectus so that I look towards the right, as well as the right medial rectus so that I can look towards the right. Is that clear? Let me talk about the pathway again, briefly. The vestibulocochlear nerve gets stimulated when the fluid within the cochlea is moving. As it does that, it is going to go and communicate with the abducens nucleus on the contralateral side. So the contralateral abducens nucleus is going to get stimulated. As this contralateral abducens nucleus gets stimulated, it goes and it constricts the lateral rectus muscle of that same eye. So of the left eye. Okay? Actually, sorry, this is the right side. I'm very sorry. This is the right side, not the left side. So when I move my head to the left, the fluid itself is shifting to the left, so that is sensed by the right side. As this shifts, I am stimulating the vestibulocochlear nerve on the right, which will move to the contralateral abducens nucleus on the left. This will stimulate the lateral rectus muscle to move to the right. So I am abducting my left eye. But at the same time, because I don't want to simply abduct the left eye, I also want to adduct the right eye, the abducens nucleus is going to communicate with the oculomotor nucleus. And it does that through something known as MLF, which is very, very important. MLF is what is known as the medial longitudinal fasciculus. What is a fasciculus? It's basically a bundle of nerves, right? So this medial, because it's on the midline, longitudinal, because it goes upwards and it's long, fasciculus, bundle of nerves, is going to communicate the signal from the abducens nucleus to the oculomotor nucleus. When this oculomotor nucleus is stimulated by the MLF, it will tell the medial rectus muscle to adduct the right eye. So the entire point is, let me just draw this out for a second. The entire point is that as I have this shift in the right side, because I am moving my head towards the left, I want my eye to shift to the right. Okay? Now, how will my eye shift to the right? Think of it this way and work your way backwards. If my eye, both of my eyes, want to shift to the right, then okay, for my right eye, that means medially. So I'm going to need the medial rectus muscle to shift it this way. What is the medial rectus muscle supplied by? Our oculomotor nerve. Our left eye, if I wanted to move right, what am I doing? I'm moving it laterally. So what am I using? The lateral rectus muscle. Lateral rectus is supplied by our abducens. So we have our LR6. Okay. Now, everything that's happening here has to communicate to each other, right? And since this abducens nucleus is not on the same side as everything else that's happening, we need to have the sort of connection that links between the two. So what happens is that the abducens nucleus will communicate with the oculomotor nucleus through this MLF. Is that clear? A bit intimidating, but it makes sense. I understand it is definitely very, very intimidating at first, but take it very systematically and take it step by step. If you guys want me to explain it again, I don't mind whatsoever. I can explain it again. Let me try to, what's the role of the fourth cranial nerve in this? Okay, so the role of the fourth cranial nerve is involved basically indirectly in the sense that what does the fourth cranial nerve act on? The superior oblique muscle, right? Which does also contribute to moving this eye medially. However, the nerve in and of itself does not do much. So it is involved since it moves the eye, but it's not involved with the entire pathway. Is that clear? Can I zoom in and draw here? I don't think so. Okay. Should I go over it one last time? Let me go over it again. Let me just very quickly add a slide that I can draw on. Okay. This is fine. Okay. All right. Let's do this again. So we have the head, this is someone's head. He has a very, very long oval head, but that's fine. His head is turning this way, okay? So head turn. So what happens is that his eyes will need to accommodate and go this way, okay? He looks like Pinocchio now. Nerve 4 or 6, that is nerve 4, okay? So what happens is that the cochlea, which is this snail-looking feature, on the contralateral side to where I'm turning. So if the person is turning to the left, oh no. If the person is turning to the left, then I will move my eyes to the right, and I will simulate the right vestibulocochlear nerve. Okay? As I stimulate this 8th cranial nerve on the right, it's going to move to the contralateral abducens nucleus, which will give the lateral rectus, okay, lateral rectus, the supply to move laterally. So it's going to move laterally. If this is the eye here, and this is the nose, it's going to move laterally. Ignore the absolute disarrangement of everything. Then on the ipsilateral side, I need to stimulate the 3rd, right? But I'm not able to do so directly through the 8th because of how far everything is. So instead, I'm going to be using our magical MLF. MLF. That's going to go to the 3rd cranial nerve, which stimulates the medial rectus muscle to also move my eye this way. All of this is happening when the head turns this way. Okay? So the entire point is that when my head is turning one way, I want to move my eyes the other way. And because of the arrangement of the eyes, if I want to move both eyes this way, then for this eye here, this right and left, this eye here, I would need to use the lateral one. And then for this eye, I would need to use the medial one. Is that clear? Yes, yes, yes. Okay, thank God. I'm really glad. I understand this can be very, very confusing. So I really hope this was helpful. It's very important to remember the MLF because if we were to have some sort of issue within the MLF, what we'd expect is basically something called loss of the doll eye reflex. You know those dolls that, specifically the girls here, I'm sure we loved them as kids, even though they're very creepy, where it would just open its eyes and then, like have this bobbly kind of head. That's very, very similar, where you're no longer able to follow along. Okay? So that is that. Now, one more thing that I want to be discussing before we move on to the sections is the facial nerve. The facial nerve is very special in the sense that it differs heavily between upper and motor neuron lesions. This is only seen really with glossopharyngeal, but it's not something that we will be discussing much. So just focus on it for the facial. And I gave it its own black background color because of how frequently this is tested and how much they really want you to focus on this. So the reason for the difference that we see is because the lower motor neuron the lower motor neuron here, is coming only from one portion. What do I mean by that? It is only getting supply from this contralateral upper motor neuron. Okay? So here, I'm only getting one. Is that clear? Meanwhile, an upper motor neuron lesion means that I am affecting those upper motor neurons here. And this is significant because I am having this dual supply. So what does this dual supply mean for me? This means that if I were to only affect this specific one, so I'm only affecting one of them, I would still have compensation by the other one. Okay? So if I were to have an upper motor neuron lesion, I am only going to be affecting one of, not two, so one of the two. So if I were to affect even this, even though it's giving two, I'm affecting this one, I still have this compensation here. I still have this ipsilateral sort of supply. On the other hand, if I were to affect the lower motor neurons, I would be cutting off any and all supply that I have to the face. Moving down to the actual level of the face itself, we have two separate branches, one supplying the forehead and one supplying the rest of the face. And obviously it's for half of the face, always. So those branches that come to the upper portion are bilateral. Meanwhile, those branches that come to this lower portion are unilateral. So what happens is that when I have an upper motor neuron lesion, i.e., I'm affecting one of those, I'm cutting off all the supply to the portion that is going to the lower face, right? It's only one supply here. So this is gone, where my pointer is. However, on this upper portion that is supplying the forehead, I have this dual supply. So even if I'm affecting this entire upper motor neuron here, I still have this compensation here, which means that the forehead is completely okay. The forehead is still getting supply. And because of this, in an upper motor neuron lesion of the facial nerve, you will have sparing of the forehead. So if you tell the patient to wrinkle their forehead and like raise their eyebrows, they'll be completely okay. They can, and you'll see them wrinkle their forehead. However, you're going to have on the same side of the affected lesion, on the lower part of the face, you're going to have this paralysis. Do you guys know if it's going to be a spastic or a flaccid type of paralysis? Link back to your spinal cord. Would it be flaccid or spastic paralysis? Spastic, since upper motor neuron lesion. Absolutely. So it is spastic because we know that this consistent contractility that occurs is through the lower motor neurons. So if we remove this inhibitory signal from the upper motor neurons, we're going to have this spastic type of paralysis where everything is super, super, super constricted. Okay? A lower motor neuron lesion is going to affect both of these lower motor neurons. And in doing so, we are no longer sparing the forehead because it doesn't have a second supply as we do here that compensates for it. And we are obviously also affecting the lower side of the face. But in this case, it would be a flaccid type of paralysis. So you'd see that the patient's entire half of the face is sagging and droopy. Does this make sense? Yes. Okay, perfect. All right, moving on to the actual sections now. Looking at this one, I want you guys to tell me which level are we looking at and why. You're going to be doing all of the work here. Upper medulla, okay. Any other guesses? Upper medulla. I agree. Okay. So everyone thinks that this is upper medulla. Someone said midbrain. Okay. So let's take a second to review cortical decussation and pyramid. Okay. So let's take a second to just review the morphology of the cross sections that I told you guys about. We said that we transition from the central canal of the spinal cord to then having the fourth ventricle posteriorly, and lastly, to having the aqueductive sylvius within the midbrain. We said that the midbrain has this Mickey Mouse sort of appearance. The spons has those two large lateral projections on either side. This medulla has this very wide sort of configuration. And we said that the medulla is very different in the upper and the lower portions. This is not the upper medulla because we do not have a fourth ventricle yet. This is, in fact, the lower medulla. So this is where I have just connected basically to my spinal cord. Does that make sense? Because we still have the morphology of the spinal cord. We still have this general appearance that we would typically see in the spinal cord. Anteriorly, we said that within the medulla, we have our pyramids. Posteriorly, we have our nucleus gracilis and our nucleus cuneatus, where they are having their decussation. Okay? So the dorsal column tract, the medial lemniscus, at the lower part of the medulla is going to have its sensory decussation. The sensory decussation happens, and then we're going to continue to have it within the midline as the medial lemniscal pathway. And it is because of this decussation that it is called the medial lemniscus, because it forms this medial portion of fibers. Okay? Is that clear? Okay. Now let's remember the configuration that I was telling you guys about with the sake of arrangement. So we said that the motor nuclei would be located more medially. Meanwhile, the sensory nuclei would be located more laterally. We also said that we would have the motor nuclei located more anteriorly, while the sensory nuclei would be located more posteriorly. Given that information, what do you guys think this might be? And remember, we're taking a section from the lower medulla, okay? And remember all the nuclei that I was telling you guys about and how I taught them to you. So this is something that is very lateral and it is posterior. Let's think about that. Lateral, okay, so that tells me that it is likely going to be what? Either special sensory afferents or it is going to be general somatic afferents, right? And then we know that it is posterior, and that is why I'm saying afferents, because it is sensory. So what type of sensory nucleus are we going to have this low within our medulla? Five, absolutely. Spinal nucleus of five. Perfect. That's an ideal answer, mashallah. Remember that our trigeminal nucleus extended the entire length of the brainstem, right? And the spinal nucleus was the one that was located within the medulla. So yes, you are absolutely correct. This is the spinal nucleus. Now on the sides here, we're going to have, once again, this is very lateral. So this is going to be some kind of sensory tract. Here, this is going to be the spinocerebellar tract, and then here is going to be the spinothalamic tract. Okay? Is that clear? Oh, yes. Okay. All right. Now here we can see this nucleus that then gives out two branches. Okay, so we have two nerves that are coming out here now, and they are located medially. So they are exiting immediately lateral to our pyramids, which basically means that it's telling me, at least, that this is within the anteromedial sulcus, right? Which was between the pyramids and our olives. 12, perfect. So this would be our hypoglossal. This hypoglossal nucleus gives us our last cranial nerve, and our first cranial nerve in this case, because we're moving from the bottom up. And this is going to be for the motor supply of the tongue. Perfect. Moving on, we started from the lower medulla. We're obviously going to go to the upper medulla. Now, I got two pictures for this because this is one of their absolute favorites to ask about. So even for lesions, I forgot so many details about a lot of things, but not about the medulla. The medulla is one that you, specifically this upper medulla, it's something that you should be very, very, very familiar with, okay? So let's take it gradually. First of all, let's orient ourselves. We have this fourth ventricle here, so I know that I'm either in the medulla or in the pons, but we do not have those huge middle cerebellar peduncles on either side, right? And the pons kind of extends downwards a bit. Also, anteriorly, we have the pyramids. So those are very indicative of the fact that we are within the medulla. Now, we have said that we've already had the decussation of the sensory pathways. So because of that, we will have this medial longitudinal fasciculus, okay? And we're going to have this medial lemniscus as well, okay? Moving to the actual portion of what these nuclei are, we're going to have this twirly looking structure, which you can very clearly see here. That is the inferior olivary nucleus. And remember what exited here between the pyramids and the inferior olivary nucleus, our hypoglossal nerve. Okay? Then we begin to try to locate our tracts. Remember, medially is motor, laterally is sensory. So our lateral spinothalamic tract is going to be here on the lateral aspect, more posteriorly. The spinal nucleus of our trigeminal is going to continue to be here since we're still within the medulla. And then lastly, we still have a lot of nerves within the medulla that we have not yet taken, right? We still said we had so many nuclei, we had so many different things that we discussed within the medulla, including the nucleus tractus solitarius, including the hypoglossal nucleus, including the vagus nucleus, including all of those. So where are those going to come from? They're going to come from this region right here, okay? All of them. Remember the nucleus ambiguous that I told you guys gives rise to the 9th and the 10th for the supply of the special visceral efferents for the pharyngeal arches. This is what that looks like. So you see how it doesn't have those very specific margins, it doesn't have a specific outline, it's just very ambiguous. That is why it is called the nucleus ambiguous. So here we had the exit of 9 and 10, right? But 10 also had its own separate vagus nucleus. And because of that, we can see this here, which is our vagus nucleus. All right. The vagus nucleus is going to be lateral to the hypoglossal nucleus, which is our most medial nerve within the medulla. Lastly, we had one more nucleus that we were talking about, which is the nucleus tractus solitarius. And that is going to be the most lateral because that is sensory. So remember it this way. The most medial is going to be motor, and the most medial is going to be hypoglossal within the medulla. As we go laterally, we're still motor, so we're going to have our vagus, and then we finally reach the actual lateral with our nucleus tractus solitarius. Moving forward a bit, we're going to have even more laterally the spinal nucleus of our trigeminal, as well as this weird nucleus ambiguous that we're not really sure what it is. Then we have our medial lemniscus, which we saw the decussation of, and our medial longitudinal fasciculus. The pyramids are always the most anterior portions, and by this point, they had already decussated. Is the upper medulla clear for everyone? Are you linking it back to the things that we've already mentioned, all the graphs and everything that we drew out? Okay, thumbs up. All right. The blood supply of the medulla is something that we've already discussed. However, medially, it is going to be by the anterior spinal artery. Laterally, it is by the vertebral artery. Ignore this pica and this posterior spinal artery for the sake of the exam. Okay? So just remember that medially, it is anterior spinal. Laterally, it is the vertebral artery. Those two are the most important by far. All right, we finished with the medulla now. Let's move on to the lower pons. How do I know that I'm within the pons? First of all, you see this basilar groove that we had within the pons, right? This is very, very indicative that, okay, now I've reached the point where the vertebral arteries actually conjoin together, where they coalesce to give me this basilar artery. So I need to have this basilar groove. We also have the fourth ventricle, and you can see that it is much larger than what we had within our medulla. Secondly, you're going to have these bodies here now, instead of the actual pyramids, which are responsible for our corticospinal tract. These are the bundles that are traveling through. Okay? Now let's take a look at the actual things that are happening, and let's remember the fact that the pons extends on either side to give me the middle cerebellar peduncles. Okay? So these fibers that are extending are our middle cerebellar peduncles. Let's try to locate everything that we did before and look at it again here. So we said that there are 4 cranial nerves within the pons. What are they? 5, 6, 7, and 8. 8 is actually at the medullary pontine junction. And it is because of that that you might be seeing this vestibular nucleus crossing and spanning between the two. So here. Okay? We talked about 8. Let's move upwards. We have cranial nerve number 7. So 7 is sensory, which means that it should be a bit more posterior. And it is sensory, it's motor, sorry. So it should be within this area rather than within this area here. And it is medial because of the fact that it is motor. So because of that, as you see, we have this motor nucleus of our facial nerve here. But what did we say? We said that the facial nerve, before it exits, it likes to loop around and create this facial colliculus around the abducens nerve. So this right here, as soon as you see this loop of the facial nerve, as soon as you see the facial colliculus, just know that the abducens nerve nucleus is going to be right underneath it. Our medial longitudinal fasciculus, our MLF, is going to continue in order for it to carry those signals. Remember, it carried them from what? From the eighth. So it's going to go starting where the eighth starts, and it's going to go up all the way to our third cranial nerve. So the medial longitudinal fasciculus is still here, right dead center. Something else that is very unique to the pons is this trapezoid body that you see here, where we have this decussation and where we have the medial lemnisci on either side. Okay, so after we've had the medial lemniscus decussating, it continues to travel within the center. And then we have this trapezoid body. We have these bundles for the corticospinal and corticonuclear fibers. We have the huge middle cerebellar peduncle, and we have this looping of the facial nerve around the abducens nerve. So we've covered cranial nerves 5, 6, 7, and 8, which is also, oh, I'm going the other way, which we can also see here. Now for 5, within the actual pons, what do we have? Do we have the spinal nucleus? Do we have the principal nucleus? Do we have the mesencephalic nucleus? What are we expecting to see? Principal nucleus, perfect. So the principal nucleus of our trigeminal is going to be within the pons. Moving on to the upper pons, we can see that most of the structures are the exact same thing. Okay, however, we begin to actually see the trigeminal nucleus. On the lower pons, we were not able to see it. So what did we see? We saw 8 here. We saw 7 looping, and we saw 6. Now here, we can have our 5th, which is the main sensory nucleus of the trigeminal nerve. So our principal nucleus. However, remember that the trigeminal nucleus, the trigeminal nerve, also has a small motor portion that we drew once again within the pons, right? And we said that it is super, super tiny, but it does provide for the muscles of mastication. So both of these are going to travel together and they're going to extend to give me the trigeminal. We can once again see the trapezoid body, we can see everything else is normal. The only difference is with the facial and the trigeminal, okay? So here we had the facial, the abducens, here we have our trigeminal. The blood supply for the pons is going to be through the basilar artery medially, and then the anterior inferior cerebellar artery laterally, so the ICA. Is this clear for everyone? Is the pons clear? So as you see, the pons does not differ that much when we move from the lower to the upper portion, but the medulla has a lot of differences. So that's why they really like to ask about the upper medulla. Is this clear? I'm trying not to spend too much time on the cross sections because I do not believe that they are as beneficial as going through the lesions, because then you'll really understand everything. But is the pons clear so far? Can we have a short break? We could, but we could do that after finishing midbrain. What do you think? Because that's the only one that we have left before we actually move to the lesions. Is that okay? All right, sure. Okay. The midbrain, once again, a lower midbrain and an upper midbrain. How do I know that I'm in the midbrain? Well, I begin to see these crus cerebri, which are these projections that are going to go to the cerebrum. Within the crus cerebri, we're going to have all of our corticospinal fibers, we're going to have our frontopontine fibers, we're going to have basically all the motor because this is super, super anterior, right? So anything you can imagine that is motor, so anything going to the pons to relay and have those corrective signals, as well as the corticospinal and corticonuclear fibers as well. So temporopontine, frontopontine, corticospinal, and corticonuclear fibers. All of those are going to travel within the crus cerebri. We also notice that we have the tectum. This tectum is where I told you guys we have our colliculi. The lower midbrain is at the level of the inferior colliculus. So here, what nucleus are we expecting to see? We're expecting to see our trochlear nucleus. Remember where we drew it, right? So the trochlear nucleus is going to be here. It's going to arise, and then it is going to loop and exit from the back of the brainstem. This is the only nerve, the only cranial nerve that exits from the back rather than from the front of the brainstem. And this is also the only nerve that goes and loops over, okay, as an upper motor neuron immediately as it exits. So we've recognized the inferior colliculus, we've recognized the trochlear nerve and its crossing over. Now, what is this huge thing? These are going to be where we have the decussation of our cerebellar fibers. So that makes sense because here we have these frontopontine fibers, we have these temporopontine. So these are going to the pons and then to eventually go to the cerebellum. So we need them to be able to have a point where they decussate from the cerebrum to the cerebellum. And this is where that happens, within the lower midbrain. Secondly, we're going to have this lateral projection here. So since it is lateral, then I am talking about something that is sensory. In order, it has the lateral lemniscus, the trigeminal lemniscus, the spinal lemniscus, and finally the medial lemniscus. So from most posterior to most anterior, I am going from purely sensory to closer to motor. So medial lemniscus is going to be closer to my motor fibers. The trigeminal lemniscus is also the mesencephalic portion of our trigeminal nerve. So this is the trigeminal portion. The lateral lemniscus, you guys know this pathway very, very well. The medial lemniscus, you guys know this pathway very well. Okay. Lastly, we move on to the upper midbrain, where we have the superior colliculus, or at the level of the superior colliculus. Once again, we're going to have the trigeminal lemniscus, spinal lemniscus, medial lemniscus. Which one are we missing here? There's one that we're missing. Lateral. Perfect. Do you guys know why we're missing the lateral lemniscus? No. Okay. So the reason why we're missing the lateral lemniscus is because it's going to go and it's going to decussate and it's going to go to the thalamus and it's going to move on. So it's no longer interested in the midbrain, basically. But that's just for your information. You don't need to actually know it. So the upper midbrain, we have trigeminal lemniscus, spinal lemniscus, and medial lemniscus. We no longer have our lateral lemniscus. The crus cerebri will continue to have all the exact same things: the frontopontine fibers, the temporopontine fibers, and the corticospinal and corticonuclear fibers. However, instead of what we saw as this huge decussation for the cerebellar portion, we have this red nucleus, which is for, what is this red nucleus for? Fair enough. So just know that it's motor, okay? That's good enough. Just know that the red nucleus is a motor nucleus, okay? So it's going to, this is where we have the extrapyramidal tracts, like the rubrospinal tract, okay? So that's why it's called red nucleus, because rubrospinal, red. Now, the medial longitudinal fasciculus, we said, wants to extend all the way from the 8th cranial nerve to the 3rd cranial nerve. And because of that, it is going to continue with us until we reach this portion right here. The way that I like to look at this section is basically like a bug. So this is the head, these are the eyes, and then these are the antennae. And whenever I see this, I remember that this is the oculomotor section. And once I see this oculomotor section, I also realize that what needs to be super, super close to it, the medial longitudinal fasciculus, the MLF, because it wants to reach the oculomotor and relay the signal from the abducens nucleus. Is that clear? Because I think just memorizing it based on cross sections gets pretty boring and pretty confusing. So try your best to link it to the functional anatomy as well as the nuclei that we have been talking about. So think about it as medial, lateral, anterior, posterior, so on and so forth. Is that clear? Clear, perfect. So for the blood supply of the midbrain, we're going to have everything by the posterior cerebral artery. Different branches of it, but all by the posterior cerebral artery. So it's very, very straightforward. That brings us to the end of the cross sections as well as the reflexes. I've gotten a request for a break, so let's take a short break. We can get back at 8:30 to continue with the actual brainstem lesions. So this is the bulk of everything that we're talking about. Would you guys like a bit more time? Would you like us to come at 8:35 instead? That's completely fine by me. I don't mind. Yes, okay, sure. All right. So we have just spoken about the reflexes. We've spoken about the cross sections. And now, just like yesterday's session where I had an introduction for like 2 hours and then I actually went to the nuclei where things actually mattered, this is this part of the session that actually matters. We're going to be looking at brainstem lesions. Now, I understand that the way that Dr. Yaqeen talks about them is super casual. You know, he just mentions names for you when you have to link things together and try to figure things out. But there is a way that, in my opinion, actually makes your life so much easier that you don't even have to remember those cross sections anymore. You don't even have to spend all of that amount of time on learning the cross sections because in the final exam, they do expect you to be able to just locate the lesion a lot better than anything else. And it's very unlikely, at least from what I've seen, for them to point out a specific nucleus and tell you what is this, like, or what can happen here. And either way, if you were to just use the clues that I told you about the general morphology as well as the position, then you should be able to figure out what that might be along with the actual clinical presentation of your patient. Talking about clinical presentation, I want us to first look at what damage would look like to each of the cranial nerves. So let's consider the oculomotor nerve. What is the oculomotor responsible for? It is responsible for, first of all, obviously, movement of the eye. Second of all, it is responsible for the opening of the eyelid. We said closure is through the facial, but the opening of the eyelid is actually through the oculomotor. It is also responsible for the constriction of the pupil. So if I were to have a damage within the oculomotor nerve, I would expect to see the opposite. First of all, I would see complete ptosis, which means that the eyelid would droop entirely, the eye would be entirely closed. I would see pupillary dilatation due to the unopposed effect of the sympathetic nervous system, since I no longer have this parasympathetic. I would have lateral strabismus, and what that means is that since I no longer am able to control the medial rectus muscle of the eye, the lateral rectus, which is controlled by the abducens, is going to have full rein to pull the eye laterally. Lastly, I'm going to have ophthalmoplegia. Second, let's talk about the trochlear nerve. The trochlear nerve is responsible for the superior oblique muscle. So we had our LR6 and our SO4. SO4, the superior oblique, is responsible for moving the eye downwards and medially. So if I were to have this type of lesion, the main presentation would be to have diplopia. I should have bolded this as well. But the abducens, on the other hand, is responsible for the lateral rectus muscle. So if I were to have a damage to the lateral rectus muscle, the medial rectus would be unopposed. And because of that, I would have this medial strabismus, or someone would come to you cross-eyed because they're no longer able to pull their eyes to the opposite end or to abduct their eyes, so abduction. Next up, we've done 3, 4, and 6. Let's move back to 5. So the trigeminal has a lot of things that it does, right? First of all, it provides the sensation to the entire face. It provides the sensation to the anterior 2/3 of the tongue, and it provides a motor supply to the muscles of mastication. So what would damage to the trigeminal look like? First of all, I would have a loss of sensation on the face and the anterior 2/3 of the tongue. This isn't the loss of taste, okay? It's loss of sensation. I would have an inability to chew because of the paralysis of the muscles of mastication. And what this would lead to is that the jaw will begin to deviate towards the lesion. Why is that? Because the muscles are going to basically start to atrophy, right? With this paralysis, and they will pull the jaw towards the side of the lesion. So if you were to tell your patient to slightly open their jaw and it deviates, that is very characteristic of a trigeminal sort of lesion. Next up, we have our facial nerve. What was the facial nerve responsible for? It was responsible for all of the motor supply to the facial expression, right? And it was responsible for the anterior 2/3 of the tongue for taste. And it was responsible for the parasympathetic supply to the lacrimal gland and to the salivary gland, specifically the submandibular and the submental. So because of that, damage to the facial nerve is going to lead to loss of taste on the anterior 2/3 of the tongue, loss of lacrimation, loss of salivation, partially at least, because you still have the parotid, and then paralysis of all the facial muscles. That depends, as we were talking about, if it is an upper motor neuron lesion or a lower motor neuron lesion. In a lower motor neuron lesion, you would have this flaccid paralysis of the entire face. Well, in an upper motor neuron lesion, you have a spastic paralysis that spares the forehead. Lastly, the facial nerve, since it exits through the internal acoustic meatus alongside the vestibulocochlear nerve, it's going to actually supply a single muscle within the ear, and that is called the stapedius muscle. The stapedius muscle is responsible for basically holding back one of the things that knocks on the eardrum, okay? And that is the stapes bone. So think of it this way. If I have an actual drum and I have this wooden stick that I'm using, if I were to hit it really, really hard on the drum, I'm going to have a very large sound, right? It's going to produce those huge sound waves. It's going to be very, very loud. So what happens is that the facial nerve comes and supplies the stapedius muscle, which basically holds back this wooden stick. If I did not have this facial nerve, what would happen? I would have this banging on the eardrum. It's going to be super loud. And because of that, I'm going to have hyperacusis, which means that I'm going to be able to hear sounds way too loudly, which can be very, very irritating. We spoke about the facial. What goes alongside the facial? The vestibular. The vestibular and the cochlear are two separate nuclei, and they have two separate functions, both for the vestibulocochlear nerve. If the vestibular portion was affected, then we would have a loss of auditory acuity. And what that means is that people would start to have like they wouldn't really be able to distinguish sounds very well. They might begin to, and this happens very often with age, right? It doesn't have to necessarily be a lesion. So they'll not be able to distinguish sounds very well. They'll not be able to hear very well. And then the cochlear portion of it is more responsible for the vomiting, vertigo, nystagmus. So this is relating to the balance. So think of yourself if you're not balanced, right? If you're about to fall, if you're getting super dizzy, all of those things are due to the cochlear nucleus of the vestibulocochlear nerve. Next up, we have our glossopharyngeal. Glossopharyngeal was responsible for what? It was responsible for the taste and sensation from the posterior 1/3 of the tongue. It was responsible for the gag reflex, right? And here this was responsible for the pupillary light reflex, right? So we would have damage to this here. And the glossopharyngeal, what else was it responsible for? It was responsible for one specific muscle in the pharynx, right? So due to that, damage to the glossopharyngeal would have dysphagia, so inability to swallow or to eat, a loss of the taste and sensation on the posterior one-third of the tongue, as well as, since it supplies the soft palate, you would have a deviation of the uvula away from the site of the lesion. Why is that? If we were to lose the glossopharyngeal, the muscles would lose their tone and they would relax, they would loosen. So the opposite side that is not affected would pull on the uvula. So it would move away from the site of the lesion. Next up, our vagabond, the vagus nerve. If we were to have an injury to the vagus nerve, typically it comes alongside the glossopharyngeal. So it's very rare for you to find it on its own. But if that happens, you would once again have your dysphagia, your dysarthria. But something that's unique to the vagus nerve is that as it travels down, it's going to give our supply to the vocal cords. And if we were to only damage one half of those vocal cords, what are we going to have? Hoarseness of the voice. So the voice is going to sound very hoarse, it's going to sound very rough. Next up, we have our spinal accessory nerve. The spinal accessory nerve is responsible for the sternocleidomastoid and the trapezius, which move the head side to side. And if we were to injure it, then we would not be able to move the head to the affected side. Lastly, we have our hypoglossal nerve that is motor to the tongue. And because of that, if you were to have a lesion in the hypoglossal nerve, the tongue would not be able to move, so the person would not be able to speak. And if you were to ask the patient to protrude their tongue, i.e., open their mouth and put their tongue out, it would deviate towards the side of the lesion. So you lick your wounds because it moves towards the side of the lesion. Is this clear for everyone? Now for the corticospinal, spinal thalamic, all of those you guys have already done in the spinal cord, so I will not be reviewing them again. But you know that if something is motor, then you would lose and you would have paralysis. If something is sensory, then you would lose that specific sensation. So either speech discrimination, vibration, conscious proprioception, pain, temperature, so on and so forth. Okay, perfect. Now let's move to what makes brainstem lesions so much easier, which is the rule of fours. The rule of fours includes 4 rules talking about 4 different things, and each one is about 4 different entities. So the first one tells me that we have 4 cranial nerves in each level of the brainstem. So remember, I told you we have 4 above the pons because we have 1 and 2 going from the brain directly, and then we have 3 and 4 within the midbrain. And then we have 4 within the pons, which are our 5, 6, 7, and 8. And then lastly, we have 4 below the pons or within the medulla. And those are our 9, 10, 11, and 12. Now, when you look at the Roman numerals, you can see that the 5s, the V's are grouped together except number 4. And then the X's are grouped together in the medulla. Okay? The second rule within the rule of fours is that we have 4 of these cranial nerve nuclei lined up within the center. Which ones are they? First of all, they're motor. And second of all, they are what 12 is divisible by. So let me think of 12. What is it divisible by? 12 is divisible by 12, obviously. It is divisible by 6. It is divisible by 4, and it is divisible by 3. 1 and 2 are not part of the brainstem, so this rule does not apply, okay? So 12, once again, divisible by 12, 6, 4, and 3. So all of those are going to be in the midline. The third rule within the rule of fours is that we have 4 structures that start with the letter M that are medial. So we have our motor tract, the corticospinal, the motor nuclei, i.e. 3, 4, 6, and 12. And then we have our medial lemniscus, okay? And we have our medial longitudinal fasciculus, which is our MLF that is responsible for the communication that leads to the vestibulo-ocular reflex. The last of our rule of fours is that we have 4 lateral structures, all that start with the letter S. So we will have our spinocerebellar, and spinothalamic. Then we would have our sensory nuclei, specifically of trigeminal, it's always lateral, and the sympathetic tracts that run on the lateral aspects of the brainstem. So let's review this very, very quickly. We have 4 cranial nerves within each brainstem. So we have 3 and 4 within the midbrain. We have 5, 6, 7, and 8 within the pons, 9, 10, 11, and 12 within the medulla. Then we have 4 cranial nerves medially, all of which 12 is divisible by. So 3, 4, 6, and 12. We have 4 medial structures that start with the letter M: medial lemniscus, medial longitudinal fasciculus, motor corticospinal tract, and the motor nuclei. Then we have 4 lateral structures that start with the letter S: spinocerebellar, spinothalamic, sensory nucleus of trigeminal, and these sympathetic tracts. Is that clear? Perfect. Now let's apply that using this drawing. And if you were to understand this drawing with me now, you're basically set. You know brainstem lesions by heart. Let's divide, first of all, our slide into 9 different quadrants. Our rows represent the midbrain, the pons, and the medulla. So in the midbrain, we said, which nuclei do we have for which cranial nerves? Three and four, exactly. Within the pons, which nuclei do we have? Five, six, seven, eight, perfect. And then within the medulla, which nuclei do we have? 9, 10, 11, 12. You're absolutely correct. Okay, so our rows are the midbrain, the pons, and the medulla. Our columns are going to be the medial aspect and the lateral aspects. So everything that I'm doing here is going to be replicated here, but just for simplicity's sake, I only did things once. But remember that everything is bilateral, okay? Everything is going to be bilateral. Now, let's talk blood supply. What supplies the lateral portion of the midbrain? Okay, so pica is for the cerebellum, right? Meanwhile, when I'm at the midbrain, I'm already beyond the level of the cerebellum. I begin to talk about the cerebrum, right? So it is posterior cerebral artery. What about the medial aspect of the midbrain? Also PCA, absolutely. Okay, what about the pons? What supplies it laterally? Ica, yes, exactly. What supplies it medially? The basilar artery. For the medulla, what supplies it laterally? The plica, and then what supplies it medially? The anterior spinal artery. Perfect. Now, we've set everything up. We have our canvas ready. Let's start actually applying the rule of fours. So our first rule was that we have 4 cranial nerves, nuclei, within each level of the brainstem. Which ones did we say were in the midbrain? We said 3 and 4. Which ones are in pons? We said 5, 6, 7, and 8. Which ones are in medulla? We said 9, 10, 11, and 12. So that's the first one gone. The second one stated that the midline of the brainstem would have nuclei that are divisible by 12 or 12 is divisible by. Which one did we say those are? 3, 4, 6, and 12, each in their specific location. Okay? Then all the remaining nuclei are going to be everywhere else around them. All right, our next one was that we have medially 4 structures that are starting with the letter M, which is our medial lemniscus. We have our corticospinal tract, which is our motor tract. We have our motor nuclei. And then finally, we have our medial longitudinal fasciculus. Okay? Obviously, the decussation for the dorsal column medial lemniscus as well as the corticospinal tract would happen at the lower level of the medulla and before this stage. So I did not want to include it here, not to confuse you guys. What was our last thing within the rule of fours? The lateral aspect would have four things. First of all, the spinal, the sensory portion of trigeminal, which we already have here. Next up, we said we'd have our sympathetic supply, which we have here. And then we'd have our spinothalamic tract and our spinocerebellar tract. Now, how does our spinocerebellar tract get to the cerebellum? It gets there through the middle cerebellar peduncle. So I included the middle cerebellar peduncle here. We obviously are also going to have the inferior cerebellar peduncle, but that's not going to affect us unless we're talking about a lesion that would actually affect this. And what that would cause is basically cerebellar ataxia, where the person has a loss of balance or they lose this unconscious, proprioception, right? They lose their conscious proprioception, sorry. Lastly, one more thing that we should be talking about is the fact that we have this substantia nigra within the midbrain, okay? This black, dark area where we have these dopaminergic nuclei that is actually part of the basal ganglia. Is that clear? Is this diagram clear for you guys? Because if you understand this, you're basically good to go for all of the lesions. So this is basically just the rule of fours applied, okay? Do you want me to go over it again? Very quickly. Yes, okay. Let's do this entire thing again. All right, so we said the rule of fours very quickly again. 4 cranial nerves in each level of the brainstem. 4 cranial nerve nuclei medially, all of which 12 is divisible by, so 3, 4, 6, and 12. 4 medial structures starting with the letter M, medial lemniscus, MLF, motor corticospinal tract, and the motor nuclei. And then 4 lateral structures that start with the letter S, spinocerebellar, spinothalamic, sensory nucleus of the trigeminal, and the sympathetic tracts. Looking at this diagram, we have our rows representing the midbrain, the pons, and the medulla. And here we are applying our first rule for the rule of fours, which is that we have the third and the fourth in the midbrain, 5, 6, 7, and 8 in the pons, 9, 10, 11, and 12 in the medulla. Now, let's apply more sustenance to this. We have our lateral aspects and our medial aspects of each. Each of those are separated based on the blood supply that actually is for them. And this is very important because when we're talking about strokes, when we're talking about lesions, we're typically referring to an artery that is defective, that is affecting this entire region. So for the midbrain, laterally and medially, we have the posterior cerebral artery, which remember was the terminal branch of the circle of Willis. For the pons, laterally, we have the anterior inferior cerebellar artery, the ICA, and then medially we have the basilar artery, that very large tortuous artery that runs in the basilar groove. For the medulla, laterally we have the posterior inferior cerebellar artery, the plica, and medially we have our anterior spinal artery. Okay. Now that that's done, let's begin to apply our second rule within the rule of fours, which said that we have 4 cranial nerve nuclei in the midline, all of which 12 is divisible by. So what were those? 3, 4, 6, and 12. And I placed each of them where they are meant to be. So 3 and 4 are meant to be in the midbrain, 6 is meant to be in the pons, and 12 is meant to be in the medulla. After that, I can place the remaining nuclei within the lateral aspects. So here we can see that the 8th is once again at the junction, okay? Meanwhile, our 9th and 10th are just in the medulla completely. So that is our second of the rule of fours. Our third one said that we have 4 structures in the midline that starts with the letter M. The first being our motor nerve nuclei. So that means our 3rd, 4th, 6th, and 12th. Remember, those are the only ones that don't have any sensory, right? They don't have anything to do with sensation whatsoever. 3rd does have parasympathetic, but that is not sensory. All of those are purely motor nerves. The second thing that we have that starts with the letter M is our motor corticospinal tract. The third thing is our medial lemniscus. So dorsal column medial lemniscus. And here we can see it moving over to go to the thalamus. Okay? What was the fourth M that is medial? Our medial longitudinal fasciculus, or our MLF. And I mentioned that the corticospinal tract and the medial lemniscus both decussate before they reach everything that we're discussing here, for simplicity's sake, okay? Because they decussate at the lower level of the medulla, either in the pyramids or at the medial lemniscus itself. Next up, we had the fourth of our rule of fours, which is that we have 4 lateral structures that start with the letter S. The first one is the sensory trigeminal nucleus, which we can already see here. The second is our sympathetic fibers. The third is our spinothalamic tract. And the fourth is our spinocerebellar tract, which would go to the cerebellum through the middle cerebellar peduncle here. And since we have a middle cerebellar peduncle, we also have the inferior cerebellar peduncle, which would only really concern us if we had its involvement, and that would translate as uncoordinated movements, loss of conscious proprioception, as well as other cerebellar signs. Lastly, we have the substantia nigra within the midbrain that is responsible for dopaminergic neurons that are defective in Parkinson's disease. It is not part of the brainstem, however, it is within the midbrain, so I have put it there. Is that clear? Is this diagram clear for everyone? Crystal, perfect, okay. Would anyone like me to repeat anything? Are we good? Because if you're good with this, my job here is done. I can go home. I can take a nap. Because now, every single lesion, all you need to do, what was the third S? Okay, so we had the sympathetic, the spinothalamic, the spinocerebellar, and the sensory of trigeminal. Those are the 4 S's. All right, perfect. Okay, now the reason why this diagram is the way that it is that now we can just do this and say, oh, so this is what would happen when the anterior spinal artery is damaged, which would mean that I'm having an issue with the medial medulla. What would be involved? The hypoglossal, corticospinal tract, and medial lemniscus. And you're done. You have just defined what the medial medullary syndrome is. You're done. Let's take a look at this. If we have an issue to the posterior inferior cerebellar artery, what are we going to affect? The lateral medulla. We're affecting cranial nerves 8, 5, 9, and 10. We're also affecting sympathetic and spinothalamic. We're done. That's it. There you go. That is lateral medullary syndrome. Now I know what it is. I know where it is. I know the artery involved. And now I can correlate any of the symptoms that I get. So what does that mean? If I have this lateral medullary syndrome, I have this stroke to the posterior inferior cerebellar artery, or PICA. This would manifest in, first of all, What's the first thing that I'm going to see? Since take it one by one. I have this affected. What is this? This is the ninth cranial nerve, so the glossopharyngeal. What did we say happens when glossopharyngeal is affected? Dysphagia, dysarthria, right? We're also going to have deviation of the uvula away from the site of the lesion. And we're going to have a decrease in salivation because of the parotid gland. We have the vagus nerve here. What does the vagus nerve do when it's defective? Dysphagia, dysarthria, and hoarseness of the voice. Here we have our trigeminal nucleus. And although it is not entirely affected, we can see that it is partially involved, right? So this involvement of the trigeminal means that we will have sensory loss. We're going to have an issue with the muscles of mastication, the deviation of the jaw, all of that. Here, we're actually going to involve, rather than the vestibular portion, we're going to be involving, sorry, rather than the cochlear portion, we're going to be involving the vestibular portion, which would give me the nystagmus, it would give me all of those features, the vertigo, this vomiting. Second, we have those tracts that are running through, the sympathetic fibers and the spinothalamic tract. What does the spinothalamic tract carry, you guys? Pain and temperature. Perfect. And we have this sympathetic. So what does this mean for me? And what do those mean for me? Something that is very characteristic of the brainstem and why I want you guys to think of the brainstem is if you have a presentation where everything is happening on one side of the face and then everything is happening on the other side of the body. So ipsilateral head and neck region, contralateral to the rest of the body. And that is the case for any of the tracts that continue down into the body because they all decussate within the lower portion of the medulla or within the spinal cord, wherever they're actually at. But they decussate before they reach the brainstem. So everything that I'm talking about with regards to cranial nerves here is ipsilateral. However, when I start to talk about tracts that are actually also within the spinal cord, then I start talking about the contralateral body rather than the face. So although the trigeminal and the spinothalamic tract are both sensory, this one is to the face, the head and neck region, and this one is to the body. So I would have loss of sensation of the ipsilateral side of the face, and loss of sensation on the contralateral half of the body, particularly pain and temperature. Pain, acute touch, and temperature. Is this clear for everyone? Does the diagram make a bit more sense now? Like, are we seeing where things are coming from? Yes, absolutely. Perfect. Okay. So this is the lateral medullary syndrome. Let's take a look at the medial medullary syndrome. What do I have affected here? First of all, it is a stroke to the anterior spinal artery. I have the hypoglossal nerve is affected. So what happens when the hypoglossal nerve is affected? We said that when you ask the patient to protrude the tongue, they lick their wounds. So it deviates towards the site of the lesion. Then we have our corticospinal tract. So once again, this is the body, right? This is something from the spine. So I will think of the contralateral hemiparalysis of both the upper and the lower limb. So that is the corticospinal tract. The dorsal column medial lemniscus also had its decussation. So once again, I will look at hemiparalysis of the contralateral side. So as hemiparesis, sorry, of the contralateral side, where what am I going to have? I'm going to have loss of tooth discrimination, vibration, and conscious proprioception to the entire contralateral half of the body. Is that clear? And since we have our MLF extending a bit here and here, just a bit, then the MLF might also begin to be involved, okay? Just keep that in mind. Is that clear? Perfect. So moving on, you guys can do the exact same thing for every single level. So let's take a look at this yellow rectangle here. We have our lateral pontine syndrome. It would be from the ICA. Here I'm affecting the cerebellar peduncle. So I'm expecting to see some kind of cerebellar ataxia. I'm also affecting the facial nerve. I'm affecting the trigeminal nerve. I'm affecting the vestibulocochlear nerve. The sympathetic tract and the spinothalamic tract are also running here, so all of these will be affected. Looking at this portion here, I would have the basilar artery affected. I would have the abducens nerve is affected, which would lead to medial strabismus, right? I would have the vestibulocochlear nerve is affected, and I would have the MLF involvement. Now, with MLF involvement, what did we say? We'd have this loss of the doll eye reflex. So the eye, if a person were to look to the side, it would no longer move along with their head. The exact same applies for absolutely everything. And I'm sure that you guys can go over this, so I don't want to waste your time by going through each of these. But I think that you understand the way that I want you to be approaching any brainstem lesion. Okay? So if you get a question that tells you a patient presents to your office with hemi paralysis, okay? Hemiparalysis of the right side of the body, alongside loss of tooth discrimination, vibration, and conscious proprioception on that side of the body, so on the left side of the body, let's say. And then they tell you that once asked to protrude their tongue, the tongue deviated towards the right. What am I thinking of here? I am thinking of, first of all, this is how I personally like to approach it. I don't like to confuse myself with the tracts and their decussations. Since something is given to me ipsilaterally, I like to think about the ipsilateral portion. So I like to think about the cranial nerves. As soon as I take note of that aspect that they told me about the tongue protrusion and moving towards the left side, then I'm thinking, okay, so what type of injury do I have here? I have an injury to the hypoglossal nerve. Where is the hypoglossal nerve? It is in the medial medulla. Okay. What else is in the medial medulla? My corticospinal tract, my dorsal column medial lemniscus. So when I have both of those affected, would I have this patient presentation? Absolutely, I would. So what is this? It is the medial medullary syndrome. Which artery is affected? The anterior spinal artery. Now, this is very straightforward and very, very, very clear. However, if I have one of the nerves that overlaps, what would I start to think? Okay, let's take an example of that. Let's say that someone presented to your office with feelings of being dizzy, they have this vertigo, they have this nystagmus. Immediately, I start to think, okay, vestibulocochlear, right? But vestibulocochlear is at this pontomedullary junction. So I'm still not really sure. I'm still not 100% like, okay, this is going to be a lateral pontine syndrome. This is where I begin to rely on other factors. I could still search for cranial nerves. So I would start to look at something that has to do with dysphagia and dysarthria. Or I could start to look at something that has to do with a spasticity of the muscles, right? Something that has to do with like sparing of the forehead. They tell you, oh, this patient was no longer able to lacrimate, for example, and that would help guide me. Otherwise, I can start to look at this here as well. So with the injury to the medial cerebellar peduncle, I begin to have these signs of ataxia, right? So you might argue, okay, we have an inferior cerebellar peduncle as well. Absolutely. So once again, what are we going back to? The cranial nerves. As we do that, we are kind of limiting our differentials. We're starting off with the common things, like including the sympathetic, including spinothalamic, and then we're trying to look at the things that we would not otherwise have anywhere else. So use this diagram to your advantage. I have included it in the slides with the animations and everything so that you can do it on your own and correlate that to the rule of fours. But if you have this diagram in your head, I guarantee you brainstem lesions will be a piece of cake, inshallah. This, alongside the table that I showed you guys for the nuclei with the JSE, SVE, all of that, Those two are what got me through brainstem and neuro. Those two are what made me actually be able to answer all of the questions. Is that clear? Do you guys have any questions? All right, perfect. Okay, now let's take a look at the individual lesions, just in case, as a review, okay? So we'll be going over lateral medullary, medial medullary, and then we'll be going over the pontine and the midbrain lesions as well. Notice how as we get to the midbrain, there isn't really much going on, right? Laterally and medially. And because of that, instead of classifying it as laterally and medially, instead of having, because everything also has the same blood supply, they mainly classify it as anterior and posterior. And what did we say was anterior for the midbrain? Which structures? Remember the functional diagram that I had where you had 3 columns. Motor. Okay, that's absolutely correct. So that motor supply is in the crus cerebri, right? And then the posterior would be the tactile area where we have our colliculi. All right. First one that we look at is the lateral medullary syndrome. This is my personal favorite. I don't know why, but it's just my personal favorite. The lateral medulla is supplied by the pica, the posterior inferior cerebellar artery. And if you were to have a clot there, what would you affect? Let's remember again. Let's look at the diagram. Okay, I'm starting to think of, what do I have? I have the sympathetic tracts, right? I have the, guys, come on, help me out. Shoot, just say things. And they're all written here anyway. I have the sympathetic pathway. I have the spinothalamic pathways. I have my ninth and 10th cranial nerves. I have my fifth cranial nerve and my eighth cranial nerve right there on the top, right? So because all of those are affected, I get this type of presentation where I have nausea, vomiting, vertigo through the vestibular nucleus. I have this ipsilateral ataxia because of the inferior cerebellar peduncle. I have ipsilateral Horner's syndrome when I'm referring to the sympathetic pathway. And what does that mean? What is Horner's syndrome? We mentioned it last session. We have partial ptosis, not complete because it's only complete when we have an injury to the third cranial nerve. Partial ptosis because the parasympathetic is basically taking over. We have anhydrosis, which means dryness of the skin, because the sympathetic is no longer able to stimulate the glands to produce the lubrication and sweat. And then we have meiosis, which basically means the constriction of the pupil, because the Edinger-Westphal nucleus is no longer opposed by the sympathetic. Since we have the involvement of the spinothalamic tract, we would have contralateral loss of pain and temperature. And then the nucleus ambiguous for cranial nerves 9 and 10 would lead to hoarseness because of the vagus and dysphagia because of the glossopharyngeal. Now, in the cross sections, you will also see, and you can also remember, that we had the solitary nucleus, the nucleus tractus solitarius. However, it does not contribute as much to the presentation as the ones that we have spoken of. So don't fixate too much on the details. Be able to recognize the larger objects in the larger picture. Now let's take a look at this. I want you guys to, first of all, tell me, is this the medulla? Is this the midbrain? Is this the pons? What are we looking at here? Medulla. Perfect. Is this upper medulla or lower medulla? Upper, exactly. Because remember the way the lower medulla looked like, right? It was very similar to the spinal cord. So here we can see that this area of the medulla is affected. So this is the medial area of the medulla, and this is called the medial medullary syndrome. Which artery was involved with this type of lesion? ASA, absolutely, the anterior spinal artery. What was in the center? Which cranial nerve did we have? 12. Perfect, hypoglossal. What did we also have? Because we're in the medial aspect. MLF, yes, absolutely. Medial lemniscus, perfect. And the last one? The pyramids, exactly. See, you didn't have to really memorize everything here, did you? Just had to know that one small slide. So now you can see that the pyramids, the medial lemniscus, and the hypoglossal are the ones that are affected, and you know the artery that is affected. So that will give me everything that I see here. So since the hypoglossal is affected, I got these straight from Dr. Yaqeen's slides so that I don't miss anything. You're going to have atrophy and fibrillation of the tongue. And then once the tongue is protruded, it will deviate towards the side of the lesion to lick your wounds. Then, since you have some kind of defect in the corticospinal tract, you're going to have this occasional upbeat nystagmus is because of MLF. Where is the one for the this one? Eh, it's not written. But you guys know that you would have contralateral hemiparalysis, right? And then for the medial lemniscal pathway, you're going to have loss of the discrimination, vibration, and conscious proprioception. This is medial medullary syndrome. Let's take a look at this now. Which level are we looking at? Are we looking at the midbrain? Are we looking at the pons? Are we looking at the medulla? The diagrams here are very helpful. Pons, yes. So this is the pons. We can see because of the protrusion that we have on either side, the fourth ventricle that we have here. And then we can see that we have this sort of issue here. This is in the ventral pontine. Okay, so this is the ventral pontine syndrome. The ventral pontine syndrome is medial. However, it only actually involves the ventral portions. So I'm talking about the basilar pons. So the ventral pontine syndrome is about the basilar aspect of the pons. It is going to affect our pyramidal tracts, leading to contralateral hemiplegia. It's going to affect the abducens nucleus, leading to the paralysis of the lateral rectus. And then it is going to affect our facial, leading to ipsilateral peripheral facial paresis. Okay. All right. Next one. This is once again the pons, but instead of only involving the ventral aspect, I am involving the entire medial aspect. So this is called the ventromedial pontine syndrome, or also just medial pontine syndrome. Here, I have everything that I did before, but I'm adding to it one specific thing, which is right here, okay? So I'm adding to it the abducens nucleus as well as the medial longitudinal fasciculus. I think I added the wrong thing here. I need to fix that. But here I'm adding the abducens and the medial longitudinal fasciculus. So you will have, once again, the same features, but with that, you will have the medial strabismus and the nystagmus. What is nystagmus? It's basically this fluttering of the eye, like the eye is no longer stable and it keeps on twitching, and that is due to the medial longitudinal fasciculus. Okay, we can see that the facial here is also looping around the abducens. Moving now to this. Is this the midbrain? Is it the pons? Is it the medulla? Midbrain, okay. Is this upper or lower midbrain? Upper. Why are we saying upper? Isn't damage to the basilar part causing quadriplegia? Yes, it does cause quadriplegia. Why? Because we are talking about the pyramidal tracts and we're affecting both of them. I told you, I think the part that I added here is incorrect. So yes, you're affecting both of them, so you will have quadriplegia. That is true. Okay. So this you guys said is upper midbrain. Why are we saying upper? We're saying it's upper because of those two cranial nerves that are popping up, which are the third cranial nerve, right? It's this bug with its antennae that go anteriorly, unlike the trochlear, which would loop around posteriorly. Okay, so when I'm talking about this type of lesion, which is super specific to the crus cerebri, I am referring to something known as Weber syndrome. Now, the way that I personally like to remember it is think of a spider web that goes and it sticks to your eye. Since it is sticking to your eye, you will have the involvement of the third cranial nerve. And then what you're going to try to do is try to basically like hush the spider web away, right? With your same hand at that same side, you're going to try to rustle it away. So since you're using that same hand, think that your opposite side is actually paralyzed. So you're only able to use the same side as this web that came and got to your eye. So because of that, we're going to have issues with the oculomotor nerve and issues with the contralateral motor supply due to the crus cerebri involvement. So this is Weber syndrome. The last one is what is known as Benedict syndrome. And I got these two for you to see that the only difference between the two is the involvement of this red nucleus. So in Benedict syndrome, you will still involve the oculomotor. You would still involve the motor supply within the crus cerebri. However, with destruction of this red nucleus, you're going to have involuntary movements. So the extrapyramidal tracts are no longer controlled. Is that clear? Yes. Okay. Now, one more thing, actually two more things that I want to stress upon is, let's say you have this type of presentation. Are we at the pons? Are we at the midbrain? Are we at the medulla? Midbrain, okay. Why are we saying midbrain? Give me your reasoning. Pons, okay, why pons? Still, same question. Give me your reasoning. Facial and abducens, absolutely. So once you see this facial colliculus, you see this abducens with the facial wrapping around it, I know immediately that I'm in pons. So if I have this type of lesion here, I'm affecting both of these, right, which are the corticospinal tracts, this pyramids. And that is what you were just talking about. This happens when I have an issue with the basilar artery, and this is called locked-in syndrome. This is a bilateral ventral pontine lesion where I have quadriplegia, I have aphasia, and I have fascicular involvement of cranial nerve number 7. So the patient is fully awake, okay? Their consciousness is not affected in any way, but they are not able to move anything. So the entire neck down is paralyzed. And the issue is that because they're fully awake, their life becomes very, very difficult. And they're only really able to just move their eyes up and down, and that's how they communicate with people. So they might say like, okay, up is for yes, down is for no, and then they just are able to move their eyes up and down. Locked-in syndrome can happen due to a basilar artery infarct or due to something else. Do you guys remember what that something else is? Rapidly corrected something. There's a specific type of electrolyte imbalance, hyponatremia, absolutely, mashallah. So rapidly corrected hyponatremia, if someone was very, very hyponatremic and then you immediately gave them a bunch of sodium, they would end up in locked-in syndrome, which is honestly a very effective way of hiding a murder. Anyways, the last thing that I want to stress upon is Horner's syndrome. So Horner's syndrome is affected when we're discussing things about the lateral aspects, right? When the sympathetic tract is involved, we have this partial ptosis, this meiosis, constricted pupils due to the unopposed action of the parasympathetic, and this anhidrosis, or the failure to sweat. So we will have dryness on the face. With that, congratulations! You guys have finished Brainstem Lesions. Did you expect them to be that easy? Be honest. I think they make a lot of sense once you actually correlate them to everything else. Yes. Okay. Kind of once you do the whole thing. Yes. Yes, exactly. So once you look at the whole picture, once you go through the table specifically, I think like, and you correlate that with everything, it just clicks into place immediately. And you can think of the patient's presentation and their symptoms and then correlate that. So this is, as I said, how I would personally approach things. Look at cranial nerves first, because they are always ipsilateral, rather than confusing myself with thinking, oh wait, no, they said that there's paralysis on the left side of the body. So that has to be something that's wrong with the right side of the medulla, right? Just go with what you know as ipsilateral first to actually be able to determine the side. And then refer back to the graph that we did to know everything that is involved within. Okay? So let's take a break so that I can also finish up the questions. I'm just pasting them in, but being very honest. I have most of them ready. Like they're all already on a separate document. I'll just paste them in so that we can actually go over them. We apologize for the delay. All right, so as I was mentioning, I have not included absolutely everything in these questions just because you have a separate PAL session on the neural anatomy portion, 4 questions entirely. So my questions are going to be more on just the basics as well as the actual lesions that we have just spoken of. You know the gist, you guys know how it goes. You have a couple of minutes to read the question, give me your answer, and then we can discuss what it actually is. B, okay. Any other answers? I think we do not have any other answers. You guys are absolutely correct. This is B. The reason why it's B is because this is the corticospinal tract, right? And since he has a loss of the right side of the body, we're going to be looking at the left side. And where do we have the corticospinal tract? Decussation after this left, because of this left side, we have it in the pyramidal part of the rostral medulla. So the pyramids and the rostral medulla would be after the decussation, so it should be on the left side. Absolutely correct. Next one. Okay, C, C. Any other answers? Going once, going twice. All right, you guys are absolutely correct. This is C. The reason for that is, first of all, the soft palate and pharynx are affected, which can either be the glossopharyngeal or the vagus. However, as we come to read hoarseness and a loss of the carotid sinus reflex, which is one of the viscera as it goes downwards, we can start to think immediately of our vagus nerve or cranial nerve number 10. All right, next one. Take it one by one, okay? Okay. Any other answers? B, I don't know. Okay. Anyone else? C, okay. So we have two C's and one B. B is actually correct, but this is super, super confusing. So, unable to salivate, when I talk about saliva, immediately think parasympathetic, general visceral, immediately. Okay? So is it efferent? Is it afferent? Our general visceral efferents were the ones that gave me the supply through the facial to the salivary glands or through the glossopharyngeal to the salivary glands. Okay? Now, since I am talking about either facial or glossopharyngeal, then I'm expecting to see other sort of defects, right? When I'm talking about the loss of the gag or the uvular reflex, I am talking about the glossopharyngeal, right? Wasn't sure where the gag reflex is. The gag reflex, as I said, the afferent fibers are through the glossopharyngeal. The efferent fibers are through the vagus nerve. Okay? So the glossopharyngeal would be general, visceral, efferent for the parasympathetic supply to the parotid gland. And then the special visceral efferent would be for the actual gag reflex. Next question. Is this the one you saw? Nope. Okay. But good job. Yes. The answer is indeed A. So the red nuclei are those cerebrospinal tracts that we spoke about in the upper midbrain. The facial colliculus lies in the cranial part of the pons. That's just, we said it is in the posterior aspect, right? The cranial part of the pons would be the superior part of the pons, and that's not the case. The motor nucleus of the trigeminal nerve lies within the caudal part of the pons. The motor nucleus of the trigeminal nerve is within the middle of the pons, basically. The abducens nucleus lies within the cranial part of the pons. It's alongside the facial nerve, so this is not the case. The trochlear nucleus lies within the midbrain at the level of the superior colliculus. The trochlear nucleus is at the level of the inferior colliculus. Next question. Mind you, by the way, it's unlikely that you'll actually be getting questions like this. You will likely be getting questions that I've gotten more towards the end, as well as questions like this. Okay, so it will often be a clinical scenario where they tell you a patient presents just like this, has difficulty producing a smile, his affected muscles are flaccid, his eyelids are open, and then they ask you to locate the lesion. So this is the type of question that you should be expecting to see within your exam. Okay, so we got B, B, B. Absolutely, you guys are correct. This is within the lower pons. So what is affected here? We have a flaccid sort of paralysis, right? The eyelids are open, and then he is unable to produce a smile from the left side of his face, the facial nerve. Exactly. Would this be the upper motor neuron lesion or a lower motor neuron lesion? Lower. Perfect. C. Okay, we finally got one answer. E. Okay. B. Okay. Okay. So the correct answer is C. Now, the reason for this is that I'm sure a lot of you just thought of cerebellar peduncles and you screw yourself over because I would have done the same. But this is cerebral peduncle. The cerebral peduncles are those projections that go up from the midbrain. And what is the most high up in the midbrain? I forgot where they were. Okay. So the cerebral peduncles are the ones that go up from the midbrain to the cerebrum. And because those are the ones that are actually affected, the most closely related cranial nerve would be the oculomotor. And since we have this right cerebral peduncle is the one that is affected, the right eye muscles would be affected since it is ipsilateral when I'm talking about cranial nerves. So the motor control of the right eye muscles. Okay? Don't freak out about this. Think of it logically. Deep. Okay. No idea. I know the answer, but I can't differentiate why it's that from this pic. Okay, so what is the answer? Ignore the picture. What is the answer? D. Ah, this is the one you saw. Okay. Yes. It is D for a very simple reason. Even if you don't actually need to know the type of tumor that this is, which is an acoustic neuroma, you don't need to know that. Look at where it is. Is this not going to the ear? Right? The ears are right here. This is where the ears are. So what goes through the internal acoustic meatus? See, I got these questions specifically because they are not what you would expect. So I wanted you guys to try to think outside of the box, just in case, because I don't know how they're gonna bring your midterm. So just in case, when you look at this, I'm not trying to tell you which type of tumor this is. I'm not trying to figure out, okay, this is that. I'm trying to look at the level that the tumor is in. And the fact that here I can see the ears and towards the ears, the internal acoustic meatus, is the passage of the seventh and the eighth cranial nerves. So the muscles of facial expression through the seventh and hearing and balance through the eighth. Does that make sense? Please don't hate me for this. Okay, perfect. Next question. B. Mm-hmm. Okay. B. All right. Any other different answers? I, it is not A. Yes, that's true. It is B. You guys are absolutely correct. So let's take this one by one. Difficulty in swallowing, some hoarseness of his voice, and giddiness was seen. Okay. So difficulty in swallowing and hoarseness of his voice means that I'm talking about the vagus nerve. On physical examination, he was found to have loss of the pharyngeal gagging reflex on the left side. Once again, vagus. Left-sided facial analgesia. So I'm talking about something that has to do with sensation here. And left-sided paralysis of the vocal cord. Once again, the vagus nerve. Based on the clinical history and the result of the physical exam, select the most likely diagnosis. Where is the vagus nerve? It is in the lateral medulla. Do I have anything within the lateral medulla that can also affect sensation? Yes, I do. I have the spinothalamic tract. So this makes perfect sense. Now I know that I am in the lateral medulla. But then I look at the choices and oh no, I'm in trouble because I have the left side and the right side. How will I know? As I told you guys, don't confuse yourselves. Cranial nerves are always ipsilateral. So if I lost the gag reflex on the left side, if I have hoarseness, if I have this difficulty of swallowing, everything on the left side, then this is on the left side as well. Okay? I hated the way this question was written, just as a heads up, but just in case, I'm trying to cover all bases. I got you this, just in case. B, okay, any other answers? B, perfect. Yes, you guys are absolutely correct. So let's take this once again step by step. Personally, I feel like in neuro, it doesn't work doing the whole just skim through the question, go to the end, and then go back to the beginning. It doesn't work for me personally in neuro. So I like to take everything step by step and then see what that means and what that translates. So first of all, we said we have meiosis, ptosis, and anhydrosis. What is this? Horner syndrome, classic. So immediately I start thinking about the lateral aspect. Then they told me it's on the left side. The hint is already there. Laryngeal and palatal paralysis on the left side. That means, what are we talking about? The vagus nerve. Facial anesthesia due to the left, the lateral spinothalamic. And then loss of pain and temperature once again from the trunk and extremities. This is, sorry, from the facial, and then this would be from the spinothalamic. So this lesion is in the medulla. It is in the lateral zone of the medulla on the left side. And it's on the rostral aspect because it's on the bottom. This rostral caudal doesn't really make that much of a difference as long as you get the rest correctly. Okay? E. Perfect. Amazing, mashallah. Yes, you're absolutely correct. This is E. Because what am I referring to here? Which nerve is affected? The third cranial nerve. Absolutely. For the rest of the four questions that we have, I am not giving you any choices. I want you to tell me where the lesion is without anything. So think of it systematically, because sometimes the choices might help you. Medial medulla, right or left? Right. Okay. Does everyone agree? Do we have any different answers? Right medial medulla? Yes. Okay, perfect. Yes, you are correct. This is the right medial medulla. Why is it the right medial medulla? When we look at weakness of the left upper and lower limbs with sparing of the face, we can tell that this is going to be the corticospinal tract after it decussates, right? The tongue deviation to the right, so I am referring to the hypoglossal nerve, which is in the medial side, and it deviates to the right, which is ipsilateral, and it is licking its wound. Loss of vibration and proprioception, so this is the medial lemniscus of the contralateral side. So this is the right medial medullary syndrome. Next one. Medial pons. Okay. Any other answers? Also specify if I'm talking about left or right. Left medial pons. Okay, do we all agree that it's left medial pons? Yes. Maybe, maybe we consider left medial is correct. No, that's right is not the issue. Left medial is correct, but it's not the pons. It's midbrain. Yes. Why is it midbrain? What is affected here? The left eye is turned downwards and out. What pulls the eye inwards? The eye part confused my brain. Okay. And the pupil is dilated. So this is all midbrain, you guys. This is all relating to the midbrain. I'm referring to the trochlear, I'm referring to the oculomotor. The pupil is dilated. A dilated pupil means I no longer have the parasympathetic supply in order to constrict my pupil. So oculomotor is affected. Weakness of the right face, upper and lower limbs. means that I'm at the level where everything is basically decussated. Everything. So that's why everything is on the other side. So the facial and the corticospinal. The eye part confused my brain. Yes, that's very valid. Is that clear? Perfect. Okay. Left medial pons, left medullary syndrome, left medial medullary. Okay. So everyone, the common thing is medial and left. So you guys are convinced this is left medial, either pons or medulla, right? No, it's medullary. So left medial medullary syndrome. Let's review what is left medial medullary syndrome. So we had an issue with the hypoglossal nerve, right? Which meant that we would have fasciculations within the tongue, we'd have paralysis of the tongue. Do we at any point here have any issue with the tongue? So that immediately should take out medial, right? We do, however, have left-sided limb ataxia. So same-sided limb ataxia is due to the involvement of the inferior cerebellar peduncle. Okay, so limb ataxia, cerebellar symptom. Left-sided alteration of pain and temperature on the face. This is due to the trigeminal. Left-sided ipsilateral Horner syndrome. This is due to the sympathetic. Right-sided alteration of pain and temperature affecting the arm and leg. This is due to the spinothalamic. Dysarthria and decreased gag reflex on the left with the palate pulling to the right side. So contralateral palate, dysarthria, decreased gag reflex on the left. This is due to the glossopharyngeal and the vagus. So all of these structures are in the lateral medulla. So this is the left lateral medullary syndrome, which is also known as the Wallenberg syndrome. And this is my favorite one. So you guys should have gotten this one right. Okay. Are we good? Do you want me to repeat it again? So this is the textbook presentation for left lateral medullary syndrome. Our last question. Well, I might just add one more, just for the sake of complacency. It is not in the slides, but I will tell you what it is. So, and I'll add it to the slides later. Pons. Okay. Lateral or medial? Lateral, okay. Right or left? Right. Perfect. Absolutely. So this is right lateral pons because everything's on the right, first of all. We have this tinnitus, which is associated with the vestibulocochlear nerve. And then we have the right-sided limb ataxia, which is through the cerebellar peduncles. The right-sided facial numbness with the loss of the corneal reflex, which is through the trigeminal and the facial. And then the right-sided hemifacial spasms due to the facial. Okay. The last question that I would ask you guys is not in the slides right now, but I will go back to just a second. What was it? Here, this slide here. Let's say I bring you a question where I have those four in front of you. Obviously, they're not going to have those written on them. But I just give you a patient presentation and I tell you that someone, why isn't the pointer popping up? I tell you that someone presents to you with hyperacusis, okay, decreased lacrimation, decreased salivation, so dryness of the mouth, dryness of the eyes, hyperacusis, and they present to you with medial strabismus. Which of these four would correlate to this type of presentation that I am talking about? Pons. Perfect. If I were to tell you to locate exactly in the pons, would it be medial or lateral? So if those were A, B, C, and D, you should be able to know that it's C, right? And it is medial, absolutely. So this is the ventromedial syndrome of the pons, where I have the involvement of the facial and the abducens, as well as the corticospinal tract, the pyramids. So alongside everything that I just told you guys, what would our patient also have? They would have contralateral hemiparalysis. Is that clear? Do you guys understand the question? Where I would just give you A, B, C, and D, and then you have to tell me, is it A, B, C, or D? So I wouldn't give you the actual labelings, I would just give you those, and it wouldn't really be like those, it would be the actual cross sections that you would see at the end. Okay? So I'd get you a picture of something like this, and I would tell you that there's a lesion here or here. Okay? So I would tell you that there's a lesion here. And sometimes they might actually bring you both of those levels. And you'd be able to recognize that here we have the facial colliculus, so it should be at the lower pons, and this is where we actually have all of our issues. To review the actual one, this is the syndrome I was talking about. Okay? And that brings me to the end of this session. I am sorry I took up so much of your time, but I really sincerely hope that this was beneficial. I understand that the brainstem is very, very, very heavy and it's very confusing for a lot of people. So I tried my best to make it in an organized way that might help you guys with your understanding, and try your best to approach things systematically. Don't overwhelm yourself. That is something that a lot of people fall into. That type of mistake where you look at the question, you see how long it is so huge, you're very overwhelmed with everything. Don't do that to yourself. Take it one by one, symptom by symptom. And then after that, your life is going to be so much easier. So someone just asked me to repeat question 3. Okay. So this is an issue, generally speaking, when I'm talking about the general somatic, general visceral. So the nucleus ambiguus, which is a component of cranial nerve number 9, is classified as a special visceral efferent fiber because it innervates the skeletal muscles and it is derived from a visceral pharyngeal arch. The inferior salivary nucleus, however, which is actually involved here, and it goes through the parotid gland, is classified as a general visceral efferent fiber. That's as simple as it is. So we have two separate nuclei, both of the glossopharyngeal, okay? So let's look at that here. Salivation is through the inferior salivatory nucleus, which is classified as a general visceral efferent. And then the supply to the pharyngeal muscles, the pharyngeal arches of the pharynx and larynx, which are involved with this uvular reflex, are through special visceral efferents. So remember, anything to do with pharyngeal arches is special visceral. Anything to do with parasympathetic is general visceral. So because of that, salivation is general visceral. The gag and uvular reflex are through the special visceral. Does that make sense? Perfect, okay. Laith, you raised your hand. Go ahead. Oops. Okay. All right. Would you guys like me to repeat any of the other questions, or are we good? I've also included an explanation to each of them within the notes section. I will just put the final touches on the slides and then send them out to you guys so that you can have them alongside the recording almost immediately. Okay?